Well, good evening, everybody. First of all, let me thank you all for coming. And I know it's a Saturday. It's a day most people do not work or are with their families. Yet here you are with us, joining us for this expert forum, helping us in the positioning of Doxoflin for the new Malaysian launch, which will be the end of this year, early next year. And we value and really appreciate that very much. So therefore, thanks again from the bottom of my heart for you all to join. Before I start introducing Professor Pang to you, which will be your chairman of the session today, please be reminded of the following rules. Please mute your microphone for the presentation section, but please do not mute your microphone for the rest of the session. We value your opinion a lot, and whether you are able to provide us with questions or suggestions through the chat, or that you would like to do it after the presentations physically through the microphone and through the camera, we would value that very much. So please do not be shy, do not be hesitant. If you have an opinion about something, please share it with us. Thank you again for joining. And I think that some of your colleagues will still be joining us during the event. But nevertheless, let's proceed. My name is Matthijs de Kleer. I am the Medical and Development Manager of Eurodrug Laboratories and of the headquarters of Eurodrug, which is situated in the Netherlands. There are also representatives from our local Malaysian office present here, for instance, Kelvin Tong and Melinda Yap. If you have any questions after the webinar or related to this meeting, don't hesitate to contact them after the session is over. I am very pleased to introduce to you our chairman for today, Professor Pang. Professor Pang is currently a senior consultant respiratory physician at the Pusat Perubatan University, Malaysia. Sorry, I had to look that one up, Professor Pang, because my Malay is not very good. He is president of the Malaysian Thoracic Society since 2017, and he has a wide range of research interests, which include lung infections, especially tuberculosis, obstructive airway disease, intestinal lung disease, and lung cancer. Furthermore, he has been very active in continuous medical education and has been invited to speak on various respiratory disorders in many scientific events nationwide and in Asia Pacific. Professor Pang, thank you so much, and please take it away.
Okay, my pleasure. Thank you very much for the very kind introduction. And good evening and good morning, depending on where you are. I think in this part of the world is 6 o'clock in the afternoon, but I think in Europe it is still in the morning. Welcome to another webinar event today. I'll be chairing and moderating today's event. As you are aware, we are gathering here in this virtual platform for a forum on the doxofylline. Doxofylline is a methyl xanthine derivative. Another derivative that all of us are quite familiar with is a theophylline. However, doxofylline is not theophylline. So exactly what is doxofylline and what is the role played by these new pharmacological agents? Let's us hear it from the experts. And joining us today, there are two very distinguished speakers in this field. They are none other than Professor Clive and Professor Visit Udompanich. Each speaker will spend about half an hour delivering a lecture. And after that, we have 30 minutes for Q&A. I think as mentioned just now, you may type in your questions in the chat box, or after the two lectures, you can also unmute yourself if you would like to ask questions verbally. And I'll move on to introduce our first speaker for today. Is Professor Clive Page, who is hailed from the United Kingdom. He's a professor of pharmacology at King's College London. And besides, he's also the director of the Sackler Institute of Pulmonary Pharmacology. He started his early career in the pharmaceutical industry of Sandoz.
Sorry, Professor Pan, your speaker has been muted. Can you please unmute yourself for a second? Yes, thank you. Sorry, please continue.
Did you hear what I mentioned just now?
Yes, you were introducing Professor Page.
Okay. So it was accidentally muted. That is okay. I thought that actually I was muted right from the beginning.
It was halfway through. Please continue.
Okay. Then I will start again, I think, for introduction of Prof. Clive Page. He's hailed from the United Kingdom, a professor in pharmacology at King's College London, and also director of the Sackler Institute of Pulmonary Pharmacology. And as alluded earlier, he started his early career in the pharmaceutical industry with Sandoz, and regularly consults both the pharmaceutical and biotech industries. He was awarded the Society of Biology President's Medal in 2012 for his outstanding contribution to life sciences. And in 2017, he was awarded the OBE. I think it's a British award for services to the pharmacology. His topic today is the role of xanthines in the treatment of respiratory diseases. What is the role of xanthine in the respiratory diseases? So over to you, Prof. Page.
So thank you very, very much, Dr. Pang, for the introduction and also for the invitation to talk to you today. As you say, I'm going to cover and discuss the role of xanthines in the treatment of respiratory diseases, and in particular, talking about doxofylline. So just to start off with, I have some potential conflicts of interest, not least that I consult, as you mentioned, to a number of organizations, not least I'm a consultant to Eurodrug, who of course are the manufacturers of doxofylline. So I don't need to tell you as a group of experts that we have a limited number of drugs for the treatment of asthma and COPD, and until recently, actually we use the same pharmacological classes of both drugs, both diseases, which is primarily the beta agonists and muscarinic receptor antagonists as bronchodilators, and also the corticosteroids as the mainstay anti-inflammatory drug. Of course, more recently for asthma, we've got biologics for severe asthma against anti-IgE and anti-IL-5, and I'll touch on at the end some of the newer anti-inflammatory drugs such as roflumilast for the treatment of COPD. And indeed, I've helped co-develop a dual phosphodiesterase inhibitor, which is currently in phase 3 for the treatment of COPD, called ensifentrine, and we may come back to that later. We also know that at the moment, many of the patients with asthma and COPD are treated with fixed dose combinations of a long-acting beta agonist and a long-acting muscarinic receptor antagonist, of which there are many variations. And of course, there are many combination inhalers of long-acting beta agonists and inhaled corticosteroids. And more recently, certainly in the UK, we've had the introduction of 2 triple inhalers, particularly for COPD, that have both a LABA, a LAMA, and an ICS. And for many patients, of course, this is effective therapy. And I believe that there are a number of fixed dose triple therapies coming along, and there's a lot of discussion about these and which is best. And in fact, obviously the devices for each of them is different. But I want to talk today really about another pharmacological class, which is namely the xanthines, such as theophyllin, and what role they have, maybe in addition to this standard of care that is increasingly becoming triple therapy. So the current place of xanthines in GINA is that, work that we've done at King's over the years and others, not least Professor Barnes, have shown that low dose of xanthines, particularly theophylline, do have an additional role on top of corticosteroids. They're currently recommended as add-on therapy at different steps in the GINA guidelines. And the majority of data that has led to this introduction has been with theophylline itself. But I'm going to show you, in fact, that doxoflin is a newer xanthine and probably a better xanthine, and that we should be aiming to try and change the word theophylline there to xanthines, including doxofylline. And as Dr. Pang said, it is a xanthine, doxofylline, and I won't go into the chemistry today, but it does have this modification from theophylline that confers some unique pharmacological properties and gives it both good efficacy, but very importantly, an improved safety profile, because as we know, xanthines have got traditionally theophylline has got a very narrow therapeutic window, and I'll come back to this later in my talk. So we know from a number of studies that doxoflin, when administered to patients with asthma, as actually in a randomized controlled study over a number of days will improve FEV1. So there's no question that, like theophylline, it is a very clear bronchodilator in comparison to theophylline itself, and certainly is significantly better than placebo. And this recent paper, which is a combination of two large studies called Dorotheo 1 and Dorotheo 2, published by my colleague Luigi Calzetta, you can see here that over time there is a very clear improvement in FEV1 with doxoflin in comparison to theophylline, and certainly in comparison to placebo, and that is actually sustained over the treatment period. And I'll come back to this later, because again, in comparison to theophylline, the number of subjects reporting side effects is reduced in comparison to theophylline, particularly when we consider one of the big issues with the theophylline itself, which is namely gastrointestinal side effects. So more recently, there is a separate study, which is an open label and a longer 1-year study in 309 patients with doxoflin, again, using FEV1 as the primary parameter, again, from Calzetta and colleagues. You can see that, again, there is a very meaningful increase in FEV1, giving doxoflin at a standard dose over time, and even at the higher dose used here compared to some countries in the world, you can see that this bronchodilation is sustained over a 1-year period. And this is actually achievable at a higher than standard dose in some countries, but with a good safety profile. So again, if you look at other secondary endpoints in this study, the amount of rescue medication required over the year in these patients, which is a common secondary endpoint in asthma studies, you can see progressively on doxoflin treatment that there is a reduction in the need for rescue medication as the asthma improves. So I think there's good evidence that doxoflin is clearly a bronchodilator and can also have this sustained effect on improving the maintenance treatment of asthma over time. And again, even at this, as in this study, a slightly higher dose given over time, there is a good safety profile, and certainly that is clear in terms of its comparison with theophylline as the standard xanthine that's used in many parts of the world. And of course, the other thing is that this is on top of standard of care. It was well tolerated in these earlier studies, but in a separate earlier study, both in patients with asthma and in all patients with COPD, you can see that doxoflin is comparable to theophylline in its ability to reduce symptoms on top of standard of care, suggesting that it does have additional clinical benefit. And again, the side effect profile of doxoflin is well tolerated and is certainly less than you see with theophylline itself. So an earlier study again, which is a randomized study, and here was looking at doxoflin with budesonide as a steroid, and in comparison to other drugs such as montelukast or tiotropium, again with the primary endpoint being improvement in FEV1 and secondary endpoint of rescue medication use. We can see here that if we look at budesonide and doxoflin here, that there is a very clear improvement in lung function over time using this treatment. And certainly it is improved in comparison, for example, which is often used is montelukast in combination as an oral therapy, where you can see that the improvements are better than that combination. And again, if we look at the rescue medication, the doxoflin administered alongside budesonide has a similar ability to reduce the need for rescue medication than using montelukast and budesonide in the treatment of subjects with asthma. And again, another study looking at a larger group of people has come to a very similar conclusion in mild to moderate asthma patients, and that is that doxoflin administered with budesonide in comparison to budesonide and montelukast, that they're very similar in efficacy, but actually doxoflin has fewer side effects. And I think it's worth reminding everyone, of course, that the FDA has recently put an FDA warning onto montelukast because of its side effects, particularly suicidal tendency, which I think is not to be forgotten, particularly when we're thinking about treating children and young adults. So one of the things that my own group published recently experimentally is that, of course, if you get additional benefit with a xanthine on top of a steroid, the question is, can you use doxoflin as a steroid sparing agent? And at least in preclinical models, we've shown that if we give doxoflin with a corticosteroid, in this case dexamethasone, we can get a very effective reduction in eosinophil infiltration into the lungs induced by allergen when we give doxoflin and steroids together. But we can do this by actually allowing 1/10 of the dose of the steroid to be used. We still get a good anti-inflammatory effect with doxoflin in the presence of steroids. And I think this is also important because the pharmacology of doxoflin, as I'll talk to you, is different to steroids and is complementary. And so in addition to giving extra benefit, it may also be used as a steroid sparing drug. And certainly in the clinic, there have been some early studies, and I know that Eurodrug are performing other studies at the moment in children in Mexico, where they are formally looking at whether doxoflin can reduce the dose of steroids required in the treatment of asthma. This is an earlier study from Patel and colleagues, which indeed shows that if you give the doxoflin with an ICS-LABA combination, that this is actually giving greater improvement than if you increase the dose of the corticosteroid, which of course has been conventional up until now. And I think this steroid sparing effect, particularly in asthmatics, could be of clinical importance. If we move to COPD, I think traditionally, sadly, COPD and asthma have been classified as similar diseases in that they're both inflammatory. But of course, we now know, not just from cigarette smoke, but also increasingly from air pollution, that the type of inflammation that characterizes COPD is distinct from asthma. It is primarily neutrophilic, except in a subgroup that may have high eosinophil numbers. There are different cytokines that drive this disease. And of course, there is a very important contribution of proteases from neutrophils and macrophages that lead both to bronchitis initially and then emphysema and alveolar wall destruction. And I think there's a growing recognition that this is a different disease and we shouldn't just treat it in the same way as asthma has been treated over years. And many of the drugs that we have for asthma have then been introduced to COPD rather than actually being specifically developed for COPD. My good friend Peter Barnes wrote a number of years ago in an excellent editorial that, of course, we've had theophyline around as a xanthine for over 70 years, but it's been relegated, as I showed you, in asthma and also in COPD to a third-line bronchodilator. But it's nonetheless recognized it is a useful treatment for COPD. And very importantly, some of the early work that Peter Barnes did with theophyline shows that its withdrawal leads to clinical worsening, even in patients taking steroids. That it has a complementary activity beyond what you can see with the steroids. And as we know, there's now a growing concern about steroid use in COPD, in that in many patients there is a higher risk of pneumonia, and therefore we do need to consider alternative anti-inflammatory drugs, particularly in this condition. And certainly our own work and Barnes and others have shown that xanthines are anti-inflammatory in addition to being bronchodilator. He has certainly shown some reversal of steroid resistance, particularly in patients with COPD. And they're also very good at reducing oxidative stress in the lung, which of course is a driving feature of COPD in comparison to asthma. So if we look again at the GOLD guidelines, again, theophylline is here as an add-on. Again, it's theophylline that's listed, not doxoflin, but my personal view, we can come back to this in the discussion, we should be considering doxoflin here as the xanthine of choice, because I think, as you'll see, it has a better safety profile, and actually there is good evidence for it working as an anti-inflammatory as well as a bronchodilator. So what is the clinical evidence in COPD that doxoflin works? Well, just as we know in asthma, if we give doxoflin in comparison to the standard theophylline, you can see that over time there is a clear improvement in lung function in this study in more than 150 patients. So not surprisingly, as we see in asthma, it is also able to induce bronchodilation when given as a maintenance treatment in patients with COPD. And one of the other things that's interesting about doxoflin, it's also been looked at in the treatment of acute exacerbations of COPD. And again, in comparison to another xanthine, ammonoflin, you can see that it's able to significantly increase FEV1 by a mean increase of up to 40%, again, suggesting that the drug is as good a bronchodilator as either theophylline or ammonoflin. Now, very importantly, with my friend Mario Cazzola, who many of you will know as an expert in COPD, we did a meta-analysis some years ago of the effectiveness of different xanthines in patients with COPD, and this was published in Respiratory Research. And we looked at all of the papers that have been published looking at the use of xanthines in patients with COPD in order to understand whether there were differences between the xanthines. Clearly, they were effective. They've been approved because they're effective, but the question is, are some superior to others? And if we look at the distribution of xanthine use in COPD patients, in over 1,000 patients that were included in the studies we looked at in this meta-analysis, you can see that the vast majority actually were taking doxoflin in comparison to theophylline, which is a much older drug, and certainly in comparison to ammonoflin and a newer xanthine called bamiflin, which I believe is only available in certain countries in Europe. But one of the interesting things that we found from this very large statistical analysis using Bayesian analysis is that you can see that the drugs that were more effective is that doxoflin was always more effective than ammonoflin to bamiflin to theophylline. So it was seen as the more superior of the xanthines in all of these studies. And you can see here that it stands out on the so-called supra-analysis that actually the risk of adverse effects was far less with treating with doxoflin in comparison to older xanthines. So the message from this is that whilst all of the xanthines have been shown to be effective, if you're going to use a xanthine, doxoflin clearly from this meta-analysis stands out as being not only more effective, but also, and I think as important, has an improved safety profile. And we looked at this both looking at a number of endpoints, the change from baseline FEV1, and you can see that by far doxoflin was as good as theophylline in this respect. It was better in comparison to other xanthines. But if we look at the risk of adverse events in the as the primary endpoint, you can see that doxoflin is always superior to ammonoflin, theophylline, and bamiflin. And that suggests that if you're going to use a xanthine, that doxoflin seems to be the better one. Now, in the context of COPD, my own group published some years ago, we've also shown that doxoflin is a very important anti-inflammatory agent. It will stop lipopolysaccharide, which of course is a contaminant of cigarette smoke and also found on bacterial cell walls. it will cause a very important neutrophil infiltration into bronchoalveolar lavage fluid. And if we treat with doxofilin, we can show that it's not only a bronchodilator, but it clearly has a good anti-inflammatory effect. And we also used a technique called intravital microscopy, where we can actually visualize neutrophils inside blood vessels. And what we see with doxofilin is that there is a clear ability to explain this anti-inflammatory effect, that doxofilin will stop the binding of cells to the blood vessel wall, and more importantly, their migration into tissues. And of course, if the neutrophils can't get into the lung, they can't cause the same degree of tissue damage that we know contributes to emphysema as a feature of COPD. And whilst I haven't got the video clips here to show you for time, if we visualize the neutrophils after the lipopolysaccharide and inflammatory stimulus, you can see lots of green cells, which are neutrophils, leaving the blood vessel here, going into the tissue. After we've administered with doxofilin, you can see we reduce the number of leukocytes leaving into the tissue. This, of course, is a characteristic of an anti-inflammatory drug. And you can see here in a healthy blood vessel, of course, there are no neutrophils migrating into the tissue. So we're absolutely convinced that doxofilin is a very powerful anti-inflammatory effect, affecting relevant cells that we know are driving the pathogenesis of COPD. And a bit like I showed you earlier with the eosinophils, we have shown that, in fact, doxofilin, when co-administered with dexamethasone as a steroid, allows you to reduce the amount of steroid that is required to produce an anti-inflammatory effect, again suggesting that doxofilin may have an important steroid sparing activity when used alongside a glucocorticosteroid. And I think that's particularly important in the context of COPD, where anything we can do to reduce steroid usage I think is important, given that there is now this very clear described risk of increased pneumonia when using steroids, particularly at higher doses. So, of course, the side effect profile of xanthines are what have led, as we've had more inhaled drugs come along, to less people using xanthines. And a lot of the side effect profile of xanthines have been described by Carl Persson and others over the years that are familiar to all of you in the audience, through the ability of xanthines like theophyllin and aminophyllin to be antagonists at adenosine receptors. And when that occurs in the CNS, in the urinary tract and the gastrointestinal tract, leads to many of the familiar side effects that we're aware of with xanthines. But some years ago, we did a comparison of doxofilin and theophyllin against the different subtypes of adenosine receptor. And what is very, very clear is that, in fact, at sensible concentrations found with doxofilin in the circulation, there is an absence of adenosine receptor antagonist with doxofilin in comparison to theophyllin, which may explain the clinical data that I showed you earlier, that it has an improved side effect profile. And the other big issue with theophyllin itself is it is also a non-selective phosphodiesterase inhibitor, and particularly phosphodiesterase 3, which is found in the heart and found in blood vessels. The inhibition of this enzyme with theophyllin may explain why it has cardiac side effects very close to the concentrations required to cause bronchodilation, which again, we see at sensible concentrations, almost no inhibition of PDEs with doxofilin, again showing that it has an improved safety profile, and explain why some of the clinical data suggests it has less cardiac side effects. So earlier studies, I've shown you some, but this is another study comparing doxofilin and theophyllin. You can see that particularly the overall tolerability is certainly improved with doxofilin, and our meta-analysis confirmed that. And particularly when we look at things like nausea, that often cause people to stop wanting to take theophyllin regularly. So I think the data suggests that doxofilin does have an improved safety profile, and I think our meta-analysis confirms that, and certainly our pharmacological studies would support a mechanism as to why that is. It is not theophyllin. It is a different chemical entity with a different pharmacological profile. And certainly other studies in the clinical literature have shown that doxofilin causes fewer nighttime arousals than patients being treated with theophyllin, another CNS stimulation has been another well-described side effect with theophylline, which is less in patients taking doxoflin. And as I mentioned around PDE3 inhibition, in comparison to aminophylline in patients with underlying cardiovascular disease, and of course this safety profile is particularly of importance in patients with COPD who have often cardiovascular comorbidities, is that there were certainly an improved cardiovascular profile in comparison in this case to aminophylline, which again would fit with the fact that doxoflin does not inhibit PDE3, whereas aminophylline and theophylline can. So if we just do a rapid comparison here, we know with theophylline there's a very narrow therapeutic window. There's often a need to measure plasma levels, which of course is another inconvenience, and particularly in children where you may not want to use it. There are a range of side effect profiles, and I haven't got time to go into this, but you're well aware that there are many drug-drug interactions when theophylline is used alongside other medications. That is not the case with doxoflin. There is a wider therapeutic window, and we think this is because there's a lack of adenosine receptor antagonism and a lack of PDE3 inhibition, leading to improved cardiovascular tolerance. And I'd just like to end up with a few slides of something that I think we often forget. Xanthines are one of the few orally active compounds we have, and particularly in COPD, I think there's a growing interest in why we need systemic oral therapy. And to remind you that triple therapy, all of these drugs have been given by inhalation to avoid systemic exposure because of the side effect profile if you give beta agonists, muscarinic receptor antagonists, and steroids orally. We cannot do this long term because of systemic unwanted effects. And again, to remind you, increasingly, people believe, and I don't need to tell this audience, that most patients with COPD don't just have a lung disease, they have a number of systemic manifestations of inflammation, particularly cardiovascular disease. And of course, we've known that spillover from the lung from cigarette smoke and also from pollution leads to systemic comorbidities. It is very difficult to treat systemic inflammation with an inhaled drug designed not to get into the blood. And I think if we look at COPD patients in the round, we should really be considering the systemic inflammation and not just the lung inflammation. And of course, therefore, an oral drug like doxoflin could be one way of doing this, because as I've shown you, it has a good tolerability profile when administered orally, even up to a year. So going forward, there are a number of approaches to try and improve COPD treatment, where we'll often have dual activity in single molecules. And the one I mentioned at the beginning that I've been involved with, ensifentrine, is just about to finish its phase 3, is a bronchodilator and anti-inflammatory in one drug, but it's still an inhaled drug and does not target systemic inflammation. And so we already have a drug class that is a bronchodilator and anti-inflammatory, which are the xanthines, such as doxoflin, and of course, they are orally active and therefore potentially have the ability to treat systemic inflammation and not just inhaled conditions. And I haven't got time to go into this, but a lot of people are now beginning to look at a whole range of drugs orally to treat systemic inflammation, particularly for COPD. I was involved recently with a study you may be aware of, looking at one of the antioxidant drugs, erdostane, as an example of an orally active drug given for a year, able to reduce COPD exacerbations. And this drug is not a bronchodilator, but it shows you if you treat systemic inflammation, you can indeed reduce exacerbations. And I think we should be treating earlier and trying to reduce exacerbations, as this study and indeed other studies have done with carbocystane and also N-acetylcysteine. And just finally, of course, we do have the PDE4 inhibitor now that's orally active, roflumilast, and it was developed specifically to be an anti-inflammatory drug to reduce inflammation in COPD. There's good evidence that it's anti-inflammatory, but as I'm sure many of you are aware, particularly if you've used this drug, it has a very, very major problem with gastrointestinal side effects, which limits the dose you can give and therefore its usefulness. And I don't think this is going to be the solution, but it does show that giving an anti-inflammatory drug orally on top of standard of care, as we know, can improve lung function and reduce exacerbations, which should be the way forward. So with that, Mr. Chairman, I'll finish my presentation and say, I think we do still require safe oral medications, despite this being a disease that's been dominated by inhaled drugs. And I think, as Price and others have shown, as we get an increasing number of inhaler products, and I've shown you just the wide range even of triple inhalers that are coming, none of these drugs will target systemic inflammation because they're designed to stay out of the blood. We need an orally active drug, and I think we have in the xanthines such a drug, and with Doxoflin, I think we have a safer version that should certainly be considered in situations where you need something in addition to the triple therapies that are out there, particularly for treating systemic inflammation. So with that, Mr. Chairman, I'll conclude and thank you for your attention.
Okay, thank you very much, Professor Page, for the very interesting talk on the role of this new xanthine, which you have shown us seems like a very promising new agents compared to the older xanthines, partly because of the lack of the side effects. And also, as you mentioned, I think we may need an oral medication to address the systemic spillover effects of the inflammation.
Yeah.
We'll come back to the discussion after the second talk. Maybe we should move on to introduce the second speaker. Is Professor Udompanich. Prof. Udompanich is a professor of medicine at the Division of Respiratory Disease and Respiratory Critical Care in Chulalongkorn University in Thailand. He graduated as a medical doctor from Rama Tibodi Hospital. In addition, he's also a board certified physician by the American Board of Internal Medicine and the American Board of Respiratory Diseases. In 1996, he was appointed the Chief of Respiratory Disease and Respiratory Critical Care of Chulalongkorn Medical School, and from 1999 to 2003, he was the President of the Thoracic Society of Thailand. Currently, Prof. Udompanich is a respiratory consultant at the Bomrangrat International Hospital. He's still very active in clinical research, especially for respiratory infections, TB, asthma, and COPD. He's going to enlighten us today on the reasons why we should be using Doxofylline. So, Prof. Udompanich, the screen is yours.
Thank you very much, Professor Tang. Since Professor Page have done an excellent job covering most of what I have to say, I'm just going to speak it off the cuff. Many slides are covered a lot better by Professor Page, so just skip over it. Of course, as he had shown, actually theophylline is very similar to caffeine. That's why we have all that gastrointestinal side effect, and also insomnia, and also palpitation. Just a brief history. Actually, it's been extracted not from coffee, but from tea. And what many of us may not know or may have forgotten, it was the most popular bronchodilator in the world during the 1970s to the mid-1980s. That at that time, it was the only systemic drug. Okay, the only oral drug, and it's very useful. It has been proven useful in asthma and COPD. It has both oral and parenteral, and it's very cheap compared to newer drugs. It has been shown by many, I will skip this because Professor Page have already gone over it, that it's been an effective bronchodilator. So why has it fallen out of favor? Mainly because there's some data coming out in 1970 compare it to epinephrine for asthma. So the potency is less, definitely. For acute asthma, you usually give epinephrine by injection during that period. That's before we have nebulizer beta-2 agonists. And when we did a comparison, it's much less potent. So many people skip it and to use epinephrine instead. And it has side effects, as again mentioned by Professor Page, because of its narrow therapeutic range. And these are many side effects. And also many very common drug interaction. So it's very difficult to use. And when the inhaler came out, it's such a marvel of new technology that many people skip it and jump right in from oral to inhaler. And when we have inhaled steroid, we said, okay, our problem with asthma is solved. We give inhaled steroid as a controller. We use inhaled beta agonist as reliever and finish. That's it. No, in fact, first, why do we still need xanthine? It's very effective orally. And don't underestimate the benefit of oral medicine. It's very easy to prescribe and people can take it when you use inhaler. Not many people can use it properly, even after careful instruction and demonstration. We study in our hospital and almost 40% of people attending our clinic cannot use inhaler properly. The contrary to, well, the con is that it's not very potent and it has frequent side effects and difficult to use. So why should we use it? Because it's more than a bronchodilator. And actually the fear of side effect is overly exaggerated because that period, most report are from people getting intravenous theophylline, that is aminophylline, which is more difficult to have a steady blood level. And right now, because even with a lot of newer asthma medicine, many people with asthma and COPD still remain symptomatic. Again, Professor Page have gone over this already, that it have a lot more other action, especially anti-inflammatory. And one thing that I would like to add is that it improves muscle function, improves strength of diaphragm, and reduce fatigability. I did a study myself about 20 years ago. When we give theophylline to COPD, chronic stable COPD, the lung function improvement happened in about 30% of them, not all of them, but all of them have improved exercise tolerance by measured by 6-minute walking distance. So you get additional benefit even without the bronchodilator effect. Okay, I'll skip all this too. So why do we need theophylline in the age of ICS, LAMA, and all other medicine? Mainly, first, many asthma can become symptomatic even with the continuous use of inhaled steroid. They can have nighttime attack. They can have breakthrough attack. During that period, what do you do? Okay, many people will give, of course, if they come to the hospital, give the nebulizer or give them steroid. For nighttime attack and for COPD, many people, actually almost all severe COPD, will remain symptomatic even with all the inhaler you use. So theophylline actually is safer, as Professor Page have alluded to. Again, this is the same slide. Professor Barnes, my good friend, he came to Bangkok so many times. We always have a good talk over dinner, and he's a strong advocate for theophylline. He always feel bad that people using it much less because it's still a very useful drug. Okay, I wouldn't go through this. This is the same slide as Professor Page. Let me just tell you how will I use doxofilin in my clinical practice. The medicine has been available in Thailand for over 10 years now. For acute asthma attack, okay, you start with either nebulizer, and when you go home, you increase the dose of inhaled steroid, hoping that you get control. But my study demonstrates that if you add doxofilin, they have much better and much faster control instead of waiting for inhaled steroid to take effect in a week. So for asthma who have deteriorating control, adding doxofilin will improve the control faster and easier without any side effect. For people who have nighttime attack, asthma, when they start to losing control, they tend to have nighttime attack. In that case, doxofilin is a perfect medicine taken at bedtime because it provides steady blood level throughout the night, and it will improve asthma control a lot faster. And people who smoke, well, of course, we would like to advise people with asthma to stop smoking, but some of them still cannot stop smoking. They seem to respond less to steroid. So in that smoking asthma, adding doxofilin will improve control. And of course, I cannot overstate this. Many people do not like inhaler. It gives them the stigma of severe disease. It gives them stigma of illness, and then can get by very well with doxofilin. For COPD, this is very dear to me. Many people with COPD, even with best treatment, still remain symptomatic. What do you do? If you add doxofilin to this group of chronic stable COPD who's already on LAMA and inhaled steroid, I have shown in my study that they improve the 6-minute walking distance, improve lung function, and reduce exacerbation. Actually, at the time of my retirement 10 years ago, I would like to do a study, and I approached some manufacturing of inhaled bronchodilator to compare it to Teophiline about reduced exacerbation, but they refused. There's no benefit for them in comparing to Teophiline, cheaper medicine, and it may even work better. So I usually use doxofilin as an add-on therapy in chronic stable COPD to improve functional performance and to improve their quality of life. So how do we use theophylline or doxofilin nowadays? When we use theophylline, as I told you already, I grew up with theophylline. At that time, it's a very common drug. And I learned how to use it without causing side effect. That is, we tend to be very cautious and start with low dose so that it provides some degree of improvement. Again, but this reduce the drug full potential. But when we have doxofilin, we can give it a higher dose without fearing a side effect or drug interaction. So theophylline, especially doxofilin, should be very effective, safe, and cheap. And this is the drug that all of us should learn how to use properly to the benefit of our patient. My student, just like many, I think in Malaysia, will ask if it's in the guideline. Yes, it is. But I am sure that the people who write in guideline nowadays have very little experience with theophylline themselves. So they just put that as an add-on and half-heartedly that it's still effective, but they don't specifically point to you when and how you should use it. I learned how to use theophylline or Santin effectively with experience, and when doxofilin first launched in Thailand, I'm very happy because you don't need much experience to use doxofilin. You start using it immediately. But again, a word of warning. If you ask people first whether they drink coffee regularly, any people who do not drink coffee regularly will have initial side effect from doxofilin. They feel palpitation, they have diuresis, they have urinate more at night, so they cannot sleep for the first day or two. So in that setting, you start with lower dose, even when doxofilin's a recommendation that you start with the full dose. I usually start with 200 milligrams for the first 2 or 3 days, then I go to the full dose. And most of them do not have any side effect whatsoever. So the doxofilin is a very useful addition for asthma and COPD control. Okay. Usually for people with severe asthma, or one thing that I should mention, when you use inhaler, the one thing that we should consider is that sometimes it did not reach small airway where the disease are. In people with asthma, sometimes they have airway obstruction, so inhaler cannot get to where it should work. Oral medicine should work better. And in people with COPD, they have chronic small airway disease with almost fixed obstruction. In that case, definitely it has been shown that theophylline or xanthine can be very effective, and doxofilin can be easier to use and as, if not more effective than theophylline. So again, to recap, how do I use doxofilin in my practice? First, for asthma with deteriorating control. How do you know they have deteriorating control? They need more reliever, more frequent use of inhaler, they have more nighttime symptoms, or they are still symptomatic even with regular ICS use. In that case, adding doxofilin will improve control in most cases. For acute asthma, if they come for acute asthma and inhale bronchodilator reliever produce only partial relief, I add doxofilin plus prednisolone for 5 to 7 days and increase inhaled steroid during that period. I have found this very effective, and I can bring all of them under a good control again. For COPD, I always use doxofilin in COPD as an addition to any long-acting bronchodilator. And it has been shown by many investigators and by my team that it reduces symptoms. Reduce exacerbation, we don't have that many cases to see whether it's significant, but we have noticed that it reduces exacerbation. It improves clearance of bronchial secretion and definitely improves exercise tolerance with minimal side effect. So to recap, again, this is just copy Professor Clive's page. Doxofilin is at least, if not more effective as theophylline. The side effect is not related to serum level, so you do not need monitoring. It has greater therapeutic index, so there's much less chance of having serious side effect. Again, and it have much less drug interaction. So I believe this doxofilin is very useful drug for asthma and COPD. And that's all. Thank you.
Thank you very much, Professor Zit, for your extremely elaborate discussion of your clinical use of doxofilin in the practical setting. Professor Pang, would you like to kick off today with a question for one of our speakers?
Okay, yeah. Thank you very much, Prof. Udompanich, for the very enlightening talks and sharing your experience, especially on the theophylline, and as in contrast with the new agent, the doxofylline, and taken us through the historical lane on the theophylline, why it was quite popular before and become less popular subsequently, and how this drug has been repurposed for the modern usage. And also, you have also helped us in better understand the clinical indication of now the newer agents, the doxofylline, how this make us actually rethink of the usage of the xanthine moving forward in the future. All right, let me see whether there's any question in the chat box. If not, then I will ask questions while you are conceiving your questions. So my first question is to Prof. Page regarding the roflumilast and doxofylline. We know that the roflumilast is recommended for COPD and is particularly recommended for people with a chronic bronchitis phenotype and those with relatively severe airflow obstruction. So my question to you is that whether this doxofylline, whether you have the same restriction or this is regardless of the phenotypes or the disease severity. What is your view on this?
Yeah, so I think roflumilast, as you say, has only been approved as add-on therapy for more severe COPD and particularly bronchitis, because that's what the trials, the regulatory trials showed. They were used over 1 year to reduce exacerbations and see a modest improvement in lung function. The big problem, though, is that with roflumilast, the approved dose is at the bottom of the dose response curve because it has so many side effects. So I think if you could quadruple the dose of roflumilast safely, it would be the perfect drug, but you can't. And that's why it's limited. It's not been approved for asthma, even though there are early studies showing it does also have benefit in asthma, because I think PD4 is an important controlling mechanism for inflammation, both in inflammatory cells in asthma and COPD. Doxoflin doesn't have the same restriction. I think a lot of the studies I showed you, both in asthma and COPD, were in mild to moderate disease. And also there are a number of pediatric studies showing that it's well tolerated in children. So I think I think the bronchitic versus emphysematous phenotype, I think very few drugs will work in emphysematous because you have irreversible tissue damage. But I think there is a growing tendency to try and identify patients with, particularly with COPD earlier, and treat them appropriately to reduce the mild exacerbations, because we know frequent exacerbators drive the decline in lung function and make it more risk later on that you have a more severe exacerbation and end up in hospital. So I think to that extent, because as you saw from the meta-analysis, doxoflin is well tolerated across the whole spectrum, I think we should be really in this field trying to pick up patients earlier, treat them earlier. And if we can treat with an oral drug like doxoflin, because it's much, much safer than theophyline from all the studies, then you've got a chance, I think, of also dealing with the systemic inflammation, because that is clear. It drives exacerbations, and inhaled drugs can have some effect, but we should be looking to really treat this as a syndrome, not just as a lung disease. So I think if you have to do a comparison with doxoflin and roflumilast, doxoflin will win in the sense that it can be used more widely, and it certainly has a much safer profile.
Yeah, thank you for the highlights. Well, I think many people were quite, I think, excited by the roflumilast initially, but it is being used in the clinical practice. I think many of us observed that the main limitation is not the effects, it's the side effects. Yeah. And yeah, I think you have also pointed out that yeah, it has also very limited, I think very narrow therapeutic windows. The low dose doesn't seem to work, but the high dose usually is compounded by significant gastrointestinal side effects. So we might have an option now.
Yeah, I think that's absolutely right. And I think you're probably aware in Korea, for example, because of the difference in BMI and the size of people in Southeast Asia compared to North America or much of Europe, the dose has been based on sort of European and North American weights of people. They've actually introduced even smaller dose, but if you go to an even smaller dose, then roflumilast, you may have less side effects, but it's not going to have the same effect. Whereas with doxofilin, you also have the benefit, it gives you acute bronchodilation. As I showed you, you get immediate bronchodilation. Roflumilast is not a bronchodilator. It will improve lung function when given over time on top of standard of care, but it's not a bronchodilator. Whereas, as you heard from the other speaker, in the acute exacerbation, this xanthine's a bronchodilator. So they have both properties in one molecule. And I think that is an important thing, because, you know, the reason we have combination inhalers is if you give a patient a bronchodilator in one inhaler, a steroid in another, the steroid's more important, but they will stop taking it because they feel no acute benefit. That's why we have combination inhalers. So the fact we have both pharmacological activities in the same molecule, I think should be exploited for good. And as the other professor said, this is really key, that we know inhaled medicines has poor adherence. If you have to take a tablet, it's well tolerated. I think we should give further consideration to that earlier.
Okay, yeah.
Thank you very much, Professor Payson. Sorry, Professor Pang. I have a question. Like, I still see no questions in the chat. So what I'm going to do is I'm going to ask Professor Visit a question first. Okay. And what I'm going to do after that is I'm going to ask one of the audience members whether how they envision that. So, for instance, Professor Visit, you already saw Professor Page's presentation, also something about steroid-sparing effect. Related to using doxofilin compared to inhaled corticosteroids or with LABA treatment, which is of course very frequent being used in COPD and asthma. What's your experience with this combination? Do you see a lot of drug-drug interactions here, or is it quite well tolerated?
Well, for doxofilin, very little, but mainly because we are aware of it, and mainly because we use it in asthma, where the people usually take a few drugs to begin with. But again, even with Teophiline, we use properly. If you know your limitation, we have very little side effect. But as I said, it's very difficult to teach people to try this until they gain experience. But for doxofilin, it's not that difficult. So initially, I try to teach all the students to use Teophiline first, but then they gave up. They just skip it and use doxofilin because it's much easier to use. There's some price difference, but not that great compared to other medicine. I would like to add allow me to add my experience on roflumilast. We tried it in COPD 7 or 8 years ago. And one thing I have found is that only about half can maintain the medicine longer than 3 months. But one thing that people like is that it makes great weight loss medicine. Yeah. Many people lose a lot of weight through diarrhea, which is not a good way. But then they feel much better, they are losing weight, but it's not the right indication, so to speak. I joke with the pharmacist that it will be a good drug for metabolic syndrome. We package it.
Yeah, well, maybe there's a positioning there for indeed an obesity treatment. But anyway, like indeed, I think like, so what you're saying is that it definitely can be used compared to ICS and LABA. Like based on what I saw right now, maybe I can ask one of the audience members which have been joining us. For instance, Dr. Tang Liang. Sorry for my pronunciation. You were already joining us quite early. Maybe you could help us out and could you share your experiences as a doctor, and based on what you saw right now, what could be a positioning for doxofilin? Do you see, would you be using it in your practice, and in what kind of situation would you consider it?
Well, I use it very often. In fact, for asthma, usually for a well-controlled asthma, sorry.
Yes, Professor.
Okay, for well-controlled asthma, usually I don't even make appointment. They know that if they need more reliever, if they have to wake up at night to use inhaler, they will come to me. And I prescribe doxofylline on almost every cases. And with that, many of them do not need any other treatment. And I don't keep them on doxofylline for long. I give them for maybe a week or 10 days. And if they're still not well, I will up inhale steroid. But for COPD nowadays, for most, I take care of many severe COPD who, no matter what magic medicine you give, still remain symptomatic. I always add on doxofylline. Start with even 1 pill a day first, see how they improve. So I use the drug off label, not by the recommended doses. But many of them tolerate and happy with the drug. I try double it to the standard dose of twice a day. And many were happy on this. I'm still afraid to use 3 times a day as Professor Page described. Actually, it might be safe, but again, because of a different weight, usually they are very thin or even maybe 50 kilo at the most. So I'm afraid to go up to three times a day.
I completely understand that, Professor Visit. To briefly go back, Dr. Tan, maybe you were asked you the question previously. Maybe you are happy to still join the conversation and share your experience.
Sorry, I have not used Doxophilian before, but I do use quite a lot of Teophiline for as an add-on therapy for our asthma or COPD patient, particularly COPD, not so much on asthma. As a bronchodilator effect of it. I think from the data shown, I think Doxophilian probably a better option than Teophiline. Yeah.
And in your experience, in your use of Teophiline, do you use it a lot next to inhalers?
Yes.
Yes, and well, it's good to hear that you consider Doxoflin. And could you explain a little bit more, like what are your thoughts right now? Now you've heard this story, in what kind of positioning you would do it? Would you do it for early COPD patients or more late stage, or?
I think it depends on the patient. Probably, I would probably still start them on inhalers and see how their response is. If let's say their response is still not very satisfactory, and probably add on another agent, something like Doxophilian. In the event probably their inhaler technique is, despite whatever we use, we see so they can't really much improve. Probably there's some role of this oral therapy.
Yeah, thank you very much. I think this was very valuable to share, indeed. I think it's also with every introduction of every new drug, I think there's some experience to be gained and some hands to also see the effects of a drug and to compare it with what you're currently using. So it's good to hear that you at least consider it and see what the effects are of the drug. So thank you for your response. Is there anyone else right now who has a question for one of our speakers? If we do not have that, maybe it's good to ask another question related to this. So for instance, what we also saw is the COVID-19 has been hitting us quite heavily. And we saw that there were a lot of people taken into the hospital. Professor Page, related to COVID-19, we had a webinar in the past already, where we also discussed a little bit what could be a clinical use of Doxoflin. What is your opinion about Doxoflin in this situation? Could it be beneficial?
I think that certainly in the UK, we have a lot of patients with long COVID. So they've got both pulmonary and non-pulmonary symptoms relating to having had COVID. And certainly there are some studies ongoing that are looking at whether doxoflin, along with other drugs, may have some benefit, particularly in people who have respiratory symptoms. But at the moment, I think there's not enough data out there to suggest that doxoflin should be used automatically in patients with long COVID. But it's certainly when they've still got ongoing symptoms to do with the lungs, I think then it's certainly something that's worth considering. But I think we need to see more published data on that. I mean, I think coming back to the last discussion, the real place for this drug is actually at the moment is add-on to others. But I think, as you've heard from a number of people, I think actually giving it early because you can tolerate it well, you may actually start to have benefits in reducing the amount of steroid that you need. We know it can reduce the amount of beta agonists that you need, so as asthma or COPD improves. So, and I think just generally, I think this field needs to start recognizing the disease earlier, because the physicians on the call know most of their COPD patients turn up very late because they're in denial from smoking. But we've got an increasing population getting COPD-like disease from never smoking, but just because they live in a polluted atmosphere. And that's raising the profile of what do we do with these people, because there are some very good studies from my good friend Visha Vazika in London that those frequent exacerbators, particularly with COPD, will drive their lung function down first. So why are we leaving them too late? We should be treating them early. But at the moment, the question is, what do you treat them with early? What do you treat the comorbidities with? And I didn't have time to cover it, but there are some very interesting studies now from Scotland, from Canada, where people who have COPD but also have cardiovascular disease have been given beta blockers by their cardiologist, and their lung function over time gets better. They use less steroids. That tells me we need to be treating the systemic manifestations of oxidant pollution, not just locally in the lung. And I think we have a drug in Doxoflin that is doing that. And I think Teophiline was doing that, but because of all the reasons we've heard about, Theophilin's sort of gone out of favor. There aren't people promoting it. It's an old drug. It has a very, very narrow window. And I think, as we heard from Professor Visit, actually, so many people now have never really ever used it. So it's difficult. The great thing about Doxoflin, it does everything that Theophiline does, but simply. So that's a simple message, I think, for both of us are saying, if you're going to pick a xanthine, pick Doxoflin.
Great. Thank you very much, Professor Page. Professor Pang, do you have further questions for us?
Okay, I'd like to ask further questions to both speakers. I think just now Prof. Visit mentioned about the Teophiline effects on the diaphragmatic strength, and also reduce fatigability. We know that Teophiline is not, it's a moderate bronchodilator. It is also an anti-inflammatory drug. It is a drug that will actually strengthen the diaphragm. So my question is, will this new drug, the doxofylline, have the same effects? Do we have any study demonstrating these effects? Any insights on this will be appreciated.
Actually, our team did a study on diaphragmatic contractility on Teophiline. We did not have a chance to do it on Doxophilin. So I imagine it would work too, because from the 6-minute walking distance that we tried, it definitely improved the 6-minute walking distance without improve the lung function. But again, I have not gone into study that the diaphragmatic activity. But one thing that just remind me is that when we use Theophiline, we tend to use rather low dose because we are so afraid or so scared of side effect. So we did not realize its full potential. I am happy with Theophiline. I've been using it all my life. Even me, I feel very reluctant to start high dose in elderly people, people with heart failure, or people with multi-pharmacy. But with this Doxoflin, it's much easier for me and for others to use it and gain experience very quickly. So I'm not saying that it's a new drug, it's an old drug. but newly made to make it easier to use.
Yeah,
and that should be a very good thing.
Yeah, I think Professor Visit's it's very important that he raised the issue of diaphragm contractility, because we know from Professor Aubier in Paris many years ago, he showed Teophiline at doses even lower than bronchodilator doses improved diaphragm contractility. So it's affecting skeletal muscle, not just smooth muscle, probably through a different mechanism than bronchodilation. And indeed, you're probably aware, Professor Visit, with my colleagues at King's, we showed many years ago that if you give low dose Theophyline, and I'm talking 3 to 6 micrograms in plasma for several weeks, you will have an anti-inflammatory effect with no bronchodilation and no safety problems. But people, that's not how they've been taught to use it. The original study said you have to get between 10 and 20 micrograms per mil, and then you're getting very close to the adverse effects that you don't want. With Doxoflin, you don't need to worry about that because you can get it with the approved dose regularly. But actually, like you, Professor Visit, you asked to do a comparative study between bronchodilators and no one wanted to do it. I actually suggested many years ago to Eurodrug that I work very closely with Professor Moxham, who, as you know, is a world authority on diaphragm contractility, to ask the question, does Doxoflin affect diaphragm contractility as well? Because I think it's a really important study and is unique to xanthines. So if you get the same effect, but you can get it with a safer xanthine, for COPD, I think this would be something that people often neglect, is that diaphragm contractility. So I really thank you for raising that, because I didn't mention it in my talk, but I think it's something unique to the xanthines.
Thank you.
To follow up on this question, can I ask another question on, just now also, I think during the Prof Visit lecture, he mentioned about the dose of Teophiline. Based on the Prof. Peter Bun's postulation that the role of Teophiline is going beyond the traditional indication. In fact, nowadays we can use a much lower dose of Teophiline simply to capitalize on their effects on sensitizing the pharmacological effects of steroids. So this will avoid the potential side effects, but then at the same time, it may enhance the combination therapy of Teophiline and the inhaled corticosteroids. So my question here, do we have any studies on Doxophilian? I think you mentioned to us that the combination of Doxophilian with the steroids dose requirement seems to be much less. So do you think that this new agent act through the similar pathway in sensitizing the dose of steroids?
It's a good question. I think one of the things that Professor Barnes has suggested is that low-dose Theophyline is working through enzymes called HDAC, and that this is a system that we know in smokers is switched off, and that by giving the two together, you get a greater effect than if you increase the dose of the steroid, which of course conventionally people have done. There aren't such studies done with Doxoflin at a molecular level. But as I showed you, we've published a number of papers preclinically in the last few years that if we combine a low dose of a steroid with Doxoflin, we get a greater anti-inflammatory effect in terms of reducing the number of inflammatory cells coming into the lung than if we increase the dose of the steroid. So I think there is both a positive cooperation, even if we're not sure of the mechanism. And the implication of that is that you can use the combination as a way of reducing steroid dosage. And as I mentioned, there is a paper now, I believe, under review with Doxoflin in children with asthma, where they've looked formally to look at steroid sparing activity, because of course, particularly in children, the lower the dose of the steroid we can give and maintain efficacy is a good thing. So I think you'll see more studies coming out supporting what Professor Barnes put many years ago, is that xanthines and steroids have complementary activity. And if you give them together, that's much better than increasing the dose of the steroids. So, and I think that will also be true in COPD, where absolutely there's concern now about using too much steroid and increasing the risk of pneumonia.
Okay.
Yes, about this.
This reminds me when Professor Barnes talked to me over, well, HDAC is his pet topic.
Yes.
What he did say is very important is that with the steroid resistant, either in asthma or COPD, use this may improve the response.
Correct.
So you don't want only to reduce the dose steroid, you want to improve the response. So I very advocate for Teophiline. No, I mean xanthine, sorry. Xanthine use in any form, because I think it does help a lot.
Yeah, you're absolutely correct. I think Professor Barnes has been particularly interested in why COPD patients often don't respond well to steroids. And it's because the oxidant metabolites will often dampen the ability of steroids to work. And with Theophiline, you can reverse that. And clinically, you make the steroids work more effectively. So you're absolutely correct.
So the other question I would like to ask is regarding the dosing. I think most study that you have shown us is a BD or a TDS dose. Is there any preparation that will make the dosing more convenient, like a daily dosing or BD dosing, or whether the company is working on some new preparation to actually reduce the frequency? What is your thought on this?
May I be so kind to answer that question?
Yes, yes, sure.
So currently we have launched Puroxan tablet and formulation in Malaysia. However, we are aiming indeed to get a single sustained release tablet out, because it will be way more convenient for patients to have a single treatment instead of double. So we are working on this treatment, and we are planning on some clinical trials, which I cannot disclose too much about. But however, indeed, this is something which is on our radar, because we believe it's very important for people to have the least amount of possible issue in having a dosage which is convenient to them. Because if you lower the barrier of taking the treatment, the patient compliance will be much higher, in our opinion, and therefore it will be valued by patients and doctors for using this treatment. So this is definitely on our radar. However, it's not the easiest thing to do, and you need to show clinical effectiveness and non-inferiority mostly, that the single release, single treatment is just as good as the BID treatment. So it's something which is a work in progress for us, but it's definitely on our radar, and we hope to provide it in the future.
If I may.
Oh, it's good to know that. I think this will certainly improve the compliance. Yes, Prof.
Yes, sir. It's very interesting. About 30 years ago, I did study on the medicine called CO24, if you remember. At the time, it claimed that it provides once a day dosage for Theophiline. At that time, we already have theoder. If you still remember, theoder is for twice a day. I did a blood level for CO24, and it showed that it made the claim that it provides steady blood level for 24 hours, but in fact, it's not true. By about 12 hours, it dropped below the therapeutic level. And I have found as a clinician that most patients will happily take the medicine twice a day. Okay, 3 times a day is difficult. Twice a day, no big deal. And I don't think it's going to be great compliance from twice a day to once a day. But anyhow, most medicine right now will be preferable to be once a day, of course. But for Theophiline, CO24 came out and it's not as good as they claim.
Yeah, no, I think as Matthias said, I think if they can get a once a day formulation, that'll be good. But I was interested to know from Professor Visit that he often starts patients just on a lower dose anyway, and then as they tolerate it, you increase the dose, because I think that's key. And I showed you the 3 times daily studies, because some of those were done in the United States, really to show you that even at a much higher dose, you still get not just effectiveness, but it's well tolerated. So, but ideally, yes, if the company could produce a once a day, I think that would definitely improve compliance. But it's the lack of compliance with xanthines tends to be that they get side effects and stop taking it,
Definitely.
which is not really your experience clinically, and I think is certainly not what the studies show. So, but you have to do a bioequivalent study effectively to show that you are getting sustained levels, because you're right, there are different theophylline preparations where they claim once daily gives the same as twice daily, but we know that's not true. You can see it also if you look at inhaled muscarinic receptor antagonists. Some countries glycopronium's once a day, other countries it's twice, the same drug. So, you know, it depends on how you interpret the data.
Can I also ask the question on the indication? Is this drug mainly being used for, indicated for adults, or it is also being indicated for children? Although I think the participants today, the majority of them are adult physicians, but I'm sure that they are also, they would like to know whether this drug is also safe for children.
I don't have any experience, but I talked to my friend who's been using it quite a bit, but not a lot, let me tell you. But they said that for usually for xanthine, sometimes you have agitation, overactive, and they said there's no problem in children because they already over agitated.
Yeah.
But again, they don't use oral medicine. It should be very good for young children. I don't know. I don't have any study, Professor Page.
I think there are, so in Georgia, I know they've got a very wide experience of using Doxoflin in pediatric indications with asthma. And there are certainly studies with Doxoflin that have been shown to be used and well tolerated in children with asthma. So I think it's not really the same problem that you have with theophylline. And certainly one of the problems with theophylline in children, as you say, they don't want to have blood levels taken. One of the first experiments I personally took part in as a volunteer many years ago was to try and measure theophylline levels in saliva as a way of measuring levels without having to take blood in children. So, you know, but you don't have, there's no need no requirement to measure blood levels, even in children with Doxoflin at the doses that have been approved. I don't know, Matthias, if there's anything else in terms of its data sheet that's approved in other countries, but I know certainly in Georgia, they have a very wide experience of it in children.
It's also, for instance, in countries like Mexico and for instance, Colombia, in Europe and Italy, the treatment is being used in children as well. I believe, from the top of my mind, it was you have to be at least 6-year-olds to take it.
Yeah.
But I need to definitely dive a little bit deeper. But the most important thing is, for instance, this clinical study you talked about, steroid-sparing effect in Mexico. This is where we're talking about asthmatic children failing to reach complete asthma control with only steroids, and they're at the brink of needing another batch of budesonide, so ICS, and they get Doxoflin, and they get their asthma controlled much better compared to without Doxoflin. So what you see here, these data is still published. We're currently in the process of publishing it. It's being peer reviewed right now. But what's really interesting here is that they treat children who need another dose of inhaled corticosteroids, which we rather not give to children. And then instead we give Doxoflin on top of it instead of increasing the dose. And you see that these children are feeling better and having a better asthma control. The current situation in Malaysia, I think that's currently I also need to check whether it's into the SPC, but I know it's for respiratory diseases right now, approved in Malaysia. So again, it is a safe drug with little side effects and even used in children already also in the clinical setting. There is some clinical data about it already available, and there's now coming another publication in children in the asthmatic setting available as well. So yes, it's definitely a treatment to use for children. However, of course, we have to be cautious to the SPC as well, and what's mentioned there, the summary of product characteristics and the patient leaflet inside of it. So that's one of the things I would like to mention. There's also a question from a participant. Are there any clinical experience with patients which fail to adhere to inhaler therapy, switching to Doxoflin or using Doxoflin on top of their inhaler therapy? Perhaps Professor Visit has one of those, an answer for us?
You have to expect people with severe COPD to not adhering because they don't believe it's helping them. Okay, I have people with COPD who come in with all the bronchodilator inhaler available in Thailand, maybe 14 of them. It's just that they keep trying, and they want immediate improvement. So they always stop using one and try the other bronchodilator. But as Professor Page pointed out, it's a systemic disease, so you need to treat the whole body. And they usually much rather prefer pills rather than inhaler, because inhaler, they expect immediate improvement, which they did not get. So I encourage them to stay on inhaler regardless and add on therapy. And again, once you take care of this severe COPD long enough, you have a good relationship. They may fight with you, but they tend to follow your advice. So I don't have much problem about them not using medicine. It's just that with all the medicine I have, even with Doxofylline, many of them still quite symptomatic. And of course, we may need other add-on medicine, which may, I don't know, Professor Page may be available in the future.
Yeah.
So I think we are running a bit late. Can I just ask one final questions regarding, I think perhaps I think many people out there are also quite interested, especially for COPD. Have been talking about these spillover effects, the so-called inflammation that spill over into the systemic circulation, resulting in other comorbidities like increased risk of diabetes, osteoporosis, skeletal dysfunction, and all these things. So my question is, do we have any study on this doxofylline trying to address the spillover systemic effects?
Not that I'm aware of. I mean, I showed the experience with erdostain, which was given orally, where you can reduce, for example, show a reduction in CRP and various cytokines in the plasma, that when you're giving an anti-inflammatory drug orally, you're getting quite a good effect on systemic inflammation. So, and certainly the experiments I showed you when we gave doxofilin with the steroid, you could see it was working at the level of the blood vessel wall to stop the leukocytes coming into the tissue, which is a requisite step to get the cells into the lung to cause the tissue damage. So I think, you know, what we need to look at is a bit like is going on now with other drugs, is to see if you're giving regularly a treatment, do you also reduce the comorbidities or improve comorbidities? And as I mentioned in my talk, there are studies where you treat the comorbidities and the lungs improve. So we know there's an overlap and an interaction, but we've not looked at it in this way, sadly. And you know, people exposed to air pollution have got a bigger risk of chronic heart failure, of systemic inflammation. We can find diesel particulates in their blood. So we know that smoking and pollution are getting into the blood. Inhaled drugs are designed not to get in the blood. So you can only really deliver an effect by having a drug that gets into the blood. So I would encourage Eurodrug and others in this field to start looking formally that when you treat with a standard dose, what you're doing to reduce systemic inflammation as an explanation as to why you have, say, a reduction in an exacerbation, and therefore you need less bronchodilator.
Definitely.
Yes, I think it's something very interesting to look at in the long run. And now we have a drug that is less side effects, and perhaps it can be used for a longer period of time. And all this, I think, is something worth exploring.
Yeah,
all right.
Agreed.
I think we are running slightly over time. I think it only leaves me to sum up this today's events. First of all, thank you very much for all of you here joining us on this evening forum. I think we have a very enlightening thoughts on the role of doxofylline as well as the clinical indication. And I'd like to thank all the two speakers for spending their precious Saturday afternoon with us, sharing your knowledge as well as your experience. I'd like to thank Drug for sponsoring these events, for getting all of us together to discuss this very interesting topic on novel agents. I'm sure that many of us benefited from this discussion. And then thank you for asking the question to make this session more interactive. I think that's all from me. I hope you will enjoy your weekends.
Thank you.
Thank you again, everybody. Okay.
Thank you, Professor Pang.
Have a good evening and good morning. Yes.
Thank you very much, Professor Pang.
Thank you.
Bye-bye.
Thank you.
Bye, everybody. Have a nice weekend.
Eurodrug. We research for the human needs of tomorrow.